Dear colleague, welcome. It's Dr. Jack Krasuski here this afternoon with Dr. Marco Grados. Dr. Grados, thank you so much for joining us here at the Wild Dunes Resort outside of Charleston. And one of your talks today was about anxiety disorders in youth. What would you like to tell us? Give us sort of like the highlights of what you believe is important for us clinicians to know about treatment. What are the what's our current knowledge base direct us towards?
Sure, thank you for the question and thank you for the invitation. Anxiety disorders in youth are important for a few reasons that are quite salient today. One is they're on the increase, and I had mentioned in the talk that maybe different reasons, not the least of which is the increased scrutiny of everyday life through social media and the higher understanding of parents and lay public about anxiety, it seems. So more and more children are coming to clinics for the treatment of anxiety, evaluation of anxiety, and even primary care. So many of our projects currently at our institution have to do working with pediatricians, which is key. And I did talk to a few of the attendees here who were pediatricians, which is interesting and good to see.
Yes.
Because they present there with the anxiety disorders often. They come to the therapist or psychiatrist at the second or third stage of their journey through treatment. The second thing to say is that it is a condition which appears early in life, whereas schizophrenia, bipolar, even major depression will appear late adolescence, early adulthood. Anxiety disorders appear early in life. And often they impact the trajectory of the child in a way that yet unknown. However, we suspect that they may make those disorders that appear later in life more likely to occur, and maybe they occur in more severe forms because anxiety was not treated at that stage. Having said that, it impacts the child at the time of the occurrence of the disorder, and in many ways. It affects social life, it affects grades, sometimes they refuse to go to school, it affects self-esteem and quality of life. We have a phenomenon that we talk about in the children with anxiety in our clinics called accommodation, and it goes both ways. The children are anxious and the parents are anxious. So the quality of life of the families are very much affected in many ways, and the interventions, and this is the third point, are quite effective.
Mm-hmm.
So we know that 70%, 80%, even in moderate to severe cases of anxiety, do very well with appropriate treatment. And here's where we run into the dilemma of our health services, where we know that the cognitive behavior therapy interventions, along with the SSRIs, especially for anxiety medications, are quite effective. The access to them is not easy for families, especially for CBT. And I did mention and talk about CBT being a good tool in the lab, in the efficacy studies, where everything's very structured and well regulated, but when you go to the community, not that many therapists are well trained and deliver CBT according to the manual. There's lots of variations, and families may not be getting the real CBT.
Right, so even therapists who clearly identify themselves as providing CBT and trained in CBT, they will often not integrate exposure therapy, as you were pointing out. And exposure therapy is only one part of the behavioral therapy. So a therapist could be giving cognitive restructuring, cognitive therapy, and even some aspects of behavioral therapy like relaxation. So they really are meeting, CBT, they are giving it. But for a lot of anxiety disorders, as you pointed out, that it's the exposure which may be the most effective, the mechanism of change, and yet often that isn't given. My joke is sort of like the other stuff you can kind of do sitting down. The exposure you have to kind of get off your butt. So I'm not kind of surprised that sometimes it kind of falls by the wayside.
It does, and many levels you have to do what you just said because you just not have to physically do it, but it can be the hardest to do.
Right. There's a resistance, right? Because you're exposing the person to anxiety and obviously people with anxiety, they've probably often perfected the maladaptive, but the coping mechanism of avoidance and escape. And now you're trying to break that, so there's going to be resistance, sometimes even from parents, let alone from the patient,
yes,
right?
The parents will feel distressed. I'm
right.
causing my child distress. Are
right.
you really asking me to do this?
Right, right. Give them a pill. Give them a pill instead.
And they do have homework to do.
Right.
So it is an art as well as a science, but it is challenging to do exposure. I will also add, especially for children, often they do not have the cognitive wherewithal to go into deep cognitive restructuring or those kind of techniques that adults can use better. So even more critical for children to engage early and more in exposures than adults.
Thank you, great point. The other thing that was very important for me to learn from your lecture was you pointed out that in medication trials of anxiety, the placebo response is quite a lot lower than depression. And one implication of that is that anxiety disorders tend not to just resolve on their own. As you mentioned, the treatment can be, when done right, can be extremely effective. 80%, that's awesome. We should celebrate that. And yet without treatment, it can often continue. It starts early in life, right? There are these temperamental predispositions, and it just can continue. And also thank you for pointing out how that the early childhood anxiety can then actually lead to this cascade of other psychopathology. I think that's very important, so I thank you for that.
Yes,
for that
and
lesson.
I will, as you're talking, of course my brain is going, yes, this is correct. And then also to mention that the mechanism of neuroplasticity is higher in children, and there's research to show this, that's why we favor the exposure therapy. But it also could be a common mechanism for other disorders. So if you deal with that mechanism early in life, you're more prepared because the vulnerability will be there. Depression also has a genetic basis, and also bipolar and schizophrenia, especially bipolar and depression, may respond to neuroplasticity mechanisms as well. And we're preparing these kids for later that may be less severe than it could have been otherwise.
So if you could put in just a nutshell, what would you recommend to us clinicians when it comes to treating the anxiety disorders? I mean, obviously there are nuances between the different ones, but as a class, what would you say would be the take-home message for us when treating anxiety disorders?
On the pharmacology side, the SSRI is pretty well established, and there's choices between them, and there's also a hierarchy of which you should probably be trying first. So that's more or less worked out, and even pediatricians should be encouraged with support from child psychiatrists to prescribe these for anxiety disorders. Many states have tip lines where the pediatrician can call support from a child psychiatrist. We have it in Maryland. It exists in Pennsylvania, and it started in Massachusetts. So encouraging and empowering pediatricians to do this, as well as educating everybody in the field. So that's the first thing. And the second thing is harder, right? The access to CBT, having pediatricians as well as child psychiatrists, networks that they can operate within when they are confident that children are going to get established structured CBT as it should be.
Yes, that's not going to be easy, but at least now you've alerted us to what question to ask or how to vet the therapist that we prescribers may want to, kind of collaborate more closely with.
Right.
So that's important in itself.
Right.
Dr. Grados, thank you so much for this brief talk. I've learned a lot, and also just for joining us for your two presentations. So thank you again.
Thank you for the opportunity.
Thank you.